Hi, everyone. Let's get started. So welcome to the Department of Emergency Medicine Grand Rounds at the Ottawa Hospital in the University of Ottawa. My name is Jim Yang, and I'm joined by my friend and colleague, Garrick. We're emergency medicine residents here in Ottawa, and it's our pleasure to talk to you this morning about COVID-19. Over the course of this talk, we're going to try to clear the air about some COVID-19 misconceptions and help you better understand this novel disease. If you have questions throughout the talk, please feel free to post them in the chat. They'll be moderated by Dr. Shahbaz Syed, who will then feed them to us at the end of the talk. A reminder to all those attending that we have colleagues joining us from across Ottawa and Canada, so just keep your comments professional in the comments. We want to start off by thanking a long list of people without whose time, expertise, feedback, and support this talk would not be possible. So we want to thank Dr. Shahbaz Syed for being our supervisor for this talk, Dr. Brandy Reed, Dr. Andrew Wilmore, Dr. Omar Anjum for contributing to the pathophysiology section of this talk, Dr. Eric Clark, Dr. Andrew G, our mentor, Dr. Nick Costain, my partner, Dr. Mary Jang, Garrick's partner, Jasmine Lee, and of course, a huge thank you to all of you in attendance today for taking time out of your busy schedule to join us this morning. Putting together this grand rounds has been one of the most challenging things we've done in our residency. With the rate of data being published, researching for this talk has felt at times like drinking from a fire hose. Many aspects of this talk have been written and rewritten multiple times due to newly published data. We endeavored to keep this material as up to date as possible. However, with the rate of data being published, the numbers presented in this talk are likely to change in the weeks and months ahead. This talk is simply a snapshot of the best available data to date, and we've included published data up to April 20th, 2020. Just a quick disclaimer before we start. We know there are a lot of controversies and opinions when it comes to COVID-19 care. We're not going to be covering airway management. We're not going to be talking about what is an aerosol generating procedure. And we're not going to be discussing novel treatments for COVID-19. If you're interested, Dr. Mike Hickey will be touching upon some of those subjects at a later date. Our goal today is simply to use the best available data to help you better understand COVID-19, its impact on our patients, and how it will affect our healthcare system. So over the course of the next 40 minutes to an hour, we're going to take you through a wide variety of topics. We're going to start with talking about pathophysiology of the virus. We're going to review the history of the disease and the current state of the pandemic. We're going to talk about the spectrum of illness of COVID-19, discuss testing and some pitfalls. And in the second half of this talk, we're going to chat about the disease course, predictors of mortality, goals of care, as well as what we're doing locally to fight COVID-19.
So what is COVID-19? It's a positive sense single-stranded RNA genome, and there's 7 known human coronaviruses to date. 4 of these strains are known to cause the common cold, and 2 of the other strains are the more deadly strains that we think about, including SARS-CoV as well as MERS. And of course, there's the newest strain and the reason why we're here today, SARS-CoV-2 or COVID-19. COVID-19 is hypothesized to be a zoonotic coronavirus, where it's passed on from bats to pangolins and then to humans. It's been found to be 96% identical to a strain of coronavirus found in bats and 99% identical to a strain of coronavirus found in pangolins. Amongst the human coronaviruses, it's most similar to SARS, where it shares 75 to 80% of its genome, and that's hence the name SARS-CoV-2. In terms of its pathophysiology, it's hypothesized to bind onto the ACE2 receptor, and specifically, it can bind onto the type 2 alveolar cells to explain some of the respiratory symptoms, as well as to the enterocytes to explain some of the GI symptoms. This table here is just to present a comparison of COVID-19 to its closest cousins, SARS and MERS, as well as to some of the more common viruses, such as the seasonal flu and the common cold. At a glance, you can see that COVID actually has a pretty similar transmissibility to SARS, as depicted by its R0, which reflects the number of people that one person can transmit the virus to. It also appears to be more transmissible than MERS. It has a slightly longer incubation period compared to SARS and MERS, with incubation period approximately 6.4 days. And from an overall case burden perspective, we see much more cases compared to SARS and MERS at 2.6 million cases worldwide to date. However, it does appear to be less severe and less fatal compared to SARS and MERS. And when we compare this to something such as the flu and common cold, these 2 viruses are very common, but they're much less severe.
We're just going to give you a quick review of the timeline of the COVID-19 pandemic. So December 8th marked the onset of symptoms of the first known case of COVID-19. On December 31st, a cluster of cases of pneumonia of unknown etiology in Wuhan was reported to the WHO. On January 7th, a novel coronavirus was identified as the cause of this new cluster of respiratory syndromes. On January 30th, the WHO declared the coronavirus as a public health emergency of international concern. On February 6th, we see a rise in the number of cases in other Asian countries such as Japan, Singapore, and South Korea. On February 23rd, coronavirus begins to spread outside of Asia with dramatic increases in the number of cases in Italy and Iran. COVID-19 reaches the shores of North America on February 29th with an outbreak in Washington state. And at the same time, we see a surge of cases across continental Europe. On March 4th, Canadian cases of COVID-19 begin to rise. It's officially declared a pandemic by the WHO on March 11th. And by April 2nd, we reach 1 million cases worldwide and 10,000 cases in Canada. On April 10th, we hit 100,000 worldwide deaths. And today, there are over 2.6 million cases worldwide and over 40,000 cases in Canada. So let's take a closer look at the Canadian data. As we can see here, there's been a quite rapid rise in the number of cases in Canada. On March 12th, we had just 103 cases, and just a bit over a month later today, we have over 40,000. This is mirrored by the death curve, where we had just 8 deaths on March 18th and over 2,000 deaths today. Looking at the Ottawa data, it's similar to the Canadian data. We started off with about 2 cases at the end of February, hitting about 100 cases in mid-March, 500 by the beginning of April, and over 900 today. Now that we've shown you some of the numbers, we're going to shift gears a little bit and discuss the clinical features of COVID-19 infection. The most well-described symptoms of COVID-19 are fever, cough, and dyspnea. Now, the caveat here is that the initial studies looking at the prevalence of fever in China used 37.3 as a cutoff, as opposed to 37.8, which is what we would consider clinical fever here. In a study by Burr et al. That looked at COVID-19 infections among healthcare workers, they found that 92% of individuals in their cohort had one of these 3 symptoms, either fever, cough, or dyspnea. And while they are common symptoms, we know that COVID-19 presents as other things, such as rhinorrhea, sore throat, myalgias, fatigue, headache, nausea and vomiting, diarrhea, and loss of smell. So as you can see, there are a broad range of symptoms associated with COVID-19 infection, with fever, cough, and dyspnea being amongst the most well-described and the most common. There are also radiographic and laboratory features associated with COVID-19 infection. From a lab work perspective, the most commonly described is lymphopenia. And radiographically, we often see ground glass opacities and bilateral consolidations described as typical findings in COVID-19 infection, where in China, they found that it was present on approximately 50% of patients who underwent CT scan. Now, a hot topic in COVID-19 discussions is the presence of asymptomatic patients. We know they exist, but we really were uncertain of their prevalence. Sutton and al. Looked at 215 pregnant women admitted for delivery in New York City between March 22nd and April 4th. 33 of these patients tested COVID positive and 88% were asymptomatic. Perhaps a better cohort is that of Burr et al. I talked about this briefly in the last slide. Essentially, it's a study that looked at reported symptoms by 4,707 COVID positive healthcare workers. And of those, 8% reported no symptoms whatsoever. But the best population level cohort data that we have probably comes from the Diamond Princess. Just as a background, the Diamond Princess is a cruise ship that suffered a COVID-19 outbreak. Occupants were forced to isolate for 14 days on the ship as it docked in a port in Japan. Aboard the Diamond Princess, there were 3,711 passengers and crew, 3,063 of which got tested, representing approximately 83% of the population. Of those tests, 634 were positive, and 328 of those positive cases were found to be asymptomatic. Now, the patients were allowed to, the occupants were allowed to disembark at the end of their 14-day quarantine. And so the authors of this paper had to use statistical modeling to factor in the patients who would develop symptoms after disembarkation and after data collection was complete. So their statistical model gave a true asymptomatic number of about 113 patients. That represents approximately 18% of positive cases. Now, this is evidence that asymptomatic cases do exist. And while this is probably the best population level data, taking into consideration numbers from other data sources, public health agencies, the best estimate of proportion of asymptomatic cases probably lies somewhere between 2 and 20%, although we have seen higher numbers in the published literature.
Now, we also received a lot of questions about the reliability of testing, with numerous reports of false negatives when using PCR testing. The early papers from China compared PCR to CT, and this raised a lot of questions about the reliability of PCR testing. I will give a disclaimer that when it comes to comparing testing, it's actually quite difficult. There's a lot of heterogeneity between different cohorts, especially with different reagents and kits being used in various different countries. Furthermore, there are factors such as handling of the specimen, the timing of the specimen, how they actually collect the specimen, that can affect the number. But this is beyond the scope of our talk, as we're not microbiologists and or biochemists. One of the bigger studies that looked at this starting off in China was by A et al., where they looked at 1,000 admitted patients who had both CT chest and PCR testing. Here they saw that they had 601 patients that were PCR positive, and of those, 97% of them had CT findings consistent of COVID. The CT chest findings they looked for consisted of ground glass opacities, consolidation, thickened interlobular septa, and nodular lesions. Of the 413 patients that tested PCR negative, they saw that 75% of these patients had CT findings that were suggestive of COVID, with 48% of them being highly likely and 33% of them being probable cases. This was reaffirmed by Long et al., where they looked at patients again with PCR testing who underwent CT chest. These patients went through initial testing as well as subsequent testing throughout their stay in hospital. What they saw was initially that 6 patients tested negative. However, all patients had CT findings suggestive of COVID at their initial presentation. When they retested them 2 to 3 days later, they saw that 3 patients were still PCR negative. And finally, when they tested them on the 3rd day, they found that all patients were now positive. And what these two studies really show is that no test is perfect. Patients may have multiple negative tests before they finally test positive. And if you have a high pre-test probability, you should assume that the patient has COVID-19. CT may be more accurate than swab, but I want to reiterate that it's actually quite impractical to CT every single patient that comes in with fever and respiratory illness. The point of these studies is to not say that we should be CTing every single patient. It's really to highlight that PCR is not perfect, and that if you really do have a high pre-test probability, you should assume that the patient has COVID-19 to be safe. Some other questions that we get asked with regards to testing is how good are these swabs? Yang et al. Looked at this in China, where they had 213 admitted patients who had PCR testing during their admission. They compared different modalities, times in the illness course, and illness severity. What they saw was when they compared oropharyngeal, nasopharyngeal, sputum, and BAL sampling, they saw that overall, that the swabs had the highest yield in the first 7 days. The yield really drops off afterwards, especially in the oropharyngeal swabs, where on the 2nd week, the accuracy drops off to 30 to 50%, and after 2 weeks, it really drops off to approximately 11 to 37%. The general trend they saw was that BAL was more accurate than sputum, and then nasopharyngeal and oropharyngeal. However, obtaining a BAL just for the purposes of testing a patient for COVID is an extremely dangerous practice, as it exposes healthcare workers to an aerosolizing generating procedure. Now, we also have been asked a lot about serologic testing. So what serologic testing is they're looking for the antibodies to the COVID virus itself, so the IgM and IgG antibodies, which are most commonly used. It's being used elsewhere in the world and will likely come to Canada in the near future. Zhao et al. Looked at 173 patients with COVID-19. And these patients were confirmed to have COVID at some point during the hospitalization. They took serial respiratory and blood samples. And what they saw was that PCR was best within the first week. However, similar to the previous study, it really degrades over time, where it worsens in the second and third weeks going forward. Compare that to serologic testing with their IgM and IgG, where they saw that serologic testing actually improves with time. However, it can be seen to be not broadly reliable until at least the second week of symptomatic illness. The median seroconversion time for IgM and IgG in this study were approximately 12 to 14 days, respectively. Other studies suggest supporting this finding of median seroconversion time of 10 to 14 days, and I would say that there's questionable utility for widespread testing of acutely ill patients using serologic testing alone, especially if it's before the 2-week mark. And what these two studies really highlight is that PCR is most accurate in the first 7 days of symptoms and really loses its reliability afterwards. Most patients will seroconvert at 10 to 14 days of illness, and serologic testing is not reliable until 2 weeks of symptom onset. It may also be that PCR and serologic testing in combination may improve reliability. However, unfortunately, it's unlikely to be broadly available to all patients right now.
So Garrick, we've heard that asymptomatic patients exist, and we've heard that PCR testing may be unreliable. However, this is still no excuse to go into the work or into public with masks like these. Garrick, I hope you put Dawn on that sponge. We're gonna progress next into talking about the disease course. So after exposure, so this data is based on 6 papers out of China. After exposure, the typical incubation period is about 6 days. Dyspnea develops somewhere between day 5 to day 8, usually. Those who need admission typically get admitted around day 7. And patients who develop critical illness and will require ICU care typically develop it sometime in the second week of illness, around days 8 to 12. We're also asked a lot about the case fatality of COVID-19. This is a chart showing the case fatality rate of COVID-19 broken down by age, as well as in 4 different countries. What we can see here is a general trend towards increased mortality with increasing age. However, as you can tell from the data from the different countries, there's a huge variation in the mortality rate. This suggests that the mortality from COVID-19 is not a function of biology alone, but rather it varies by age, healthcare system, culture, and government policy. The bottom line here is that mortality is modifiable, and there are certainly things that we can do to reduce it. This is a closer look at the Canadian data. Again, this is looking at rates of hospitalization, ICU admission, and case fatality broken down by age group. And this is a similar comparison based on US data. Again, we see a general trend towards increased hospitalization, increased ICU admission, and increased case fatality as with increasing age. And here's the Ottawa data. Unfortunately, public health does not provide age-based mortality data, so I could only give you the total mortality, but it generally follows that same trend. And comparing the Ottawa and Canada numbers, it looks like we're on about the same track. Now, a big caveat for the Ottawa and Canada numbers is that these are probably underestimations of the true rates of hospitalization and ICU admission, as hospitalization data is not available for all reported cases. So we know that some people get hospitalized, and we know that some people get really sick. So the question that we had to ask ourselves now is there clinical data that can help us identify which patients are at risk of becoming critically ill or dying? There are numerous papers that have looked at predictors of critical illness and mortality, and there are a couple. First of which is hypoxia. A paper by Petrilli et al. From New York City showed that patients presenting with an O2 sat of less than 88% had an increased chance of becoming critically ill with an odds ratio of about 7. We've seen from previous slides that critical illness and mortality increase with age. But what's probably more important is that they also increase with comorbidities. Now, the odds ratios vary between specific comorbidities, with it being somewhere between 1 to 5. But we want to highlight that the presence of a comorbidity and frailty itself is probably more important than age alone. Lastly, there are lab findings associated that predict increased mortality and critical illness. Specifically, elevations in the LDH, D-dimer, CRP, ferritin, and troponin. And we know that our medicine colleagues are already beginning to send some of these blood work in patients that they're admitting. Now, The multiple papers that look at these lab findings have a very broad range of odds ratios, and we didn't feel that the odds ratios themselves were in the scope of this talk. If you're interested, just message me afterwards. I'm happy to share the data with you. So of these patients that do end up needing admission, what are their outcomes like? So published data from China and the US suggested a ICU admission rate of approximately 26%. Now in China, after they had better control of the epidemic, it appears that their ICU admission rates have fallen. Public health data from Italy, Canada, and Ottawa further support this notion that approximately 20 to 30% of patients admitted to hospital may end up in the ICU. Amongst patients admitted to hospital, we saw a broad range of mortality rates in the published literature, ranging from somewhere between 1 to 4% in the Chinese literature to 15% in the US literature. So we've seen that up to 20 to 30% of patients may end up in the ICU. So what happens to these patients when they do go to the ICU? Well, there appears to be an extraordinarily high rate of mortality, with Chinese, Italian, US, and UK data estimating mortality to be somewhere between 50 to 60% amongst patients admitted to the ICU. And unfortunately, it looks even worse for patients on mechanical ventilation, with Chinese, American, and British data suggesting a mortality of somewhere between 70 to 80% for those intubated. So what happens to these patients when they suffer an in-hospital cardiac arrest? Well, Xiao et al. Looked at this very question. They studied the outcomes of 136 patients with in-hospital cardiac arrest in Wuhan. Out of these 136 patients, 90% had asystole as their initial rhythm. They were only able to achieve ROSC in 13% of these patients and had a 30-day survival of just 3%. And out of this entire cohort, just a single patient, or 0.7%, survived with a functionally favorable neurologic outcome. Now, to compare and contrast, our best estimates of in-hospital cardiac arrest survival from contemporary literature suggest that it's somewhere between 10 to 20%. And furthermore, in the Paramedic 2 trial that looked at functionally favorable neurologic survival in patients suffering out of hospital cardiac arrest, they had a rated their primary outcome of 2%. And we would certainly expect patients who have an arrest in hospital to have much better outcomes than those who arrest outside. So the bottom line here is that frailty may be a better predictor of mortality than age. We know that the prognosis is extremely poor in patients requiring critical care, with mortality being over 50% in patients with COVID-19 admitted to the ICU. It's even worse in intubated patients, as more than 2/3 of those patients go on to die. And cardiac arrest outcomes in patients with COVID-19 are absolutely abysmal, with less than 1% surviving with a favorable neurologic outcome. So all of these stats highlight the importance of establishing goals of care early on when managing sick patients with COVID-19. This, at the end of the day, this is both to prevent patient suffering as well as be responsible stewards of our healthcare resources.
Now, what are we doing here in Ottawa specifically? What is our local strategy? And for this, I need to give a big thank you to Dr. Andrew Wilmore, who sat down with us virtually, of course, to help us with a lot of this talk and explaining about what's going on behind the scenes. He's our emergency management guru, crisis manager, slayer of bureaucracy, and slasher of red tape, who's been putting in 12 to 16 hours a day since the beginning of the pandemic, and deserves a huge amount of credit for the success of our robust local COVID strategy, even if he won't take any of that credit himself. What he explained to us was a multifaceted strategy that exists to manage these COVID patients in our region. First, members of the public seeking care may be directed to a variety of different resources. If these patients appear well, they can go to the assessment center at Brewer, where they're able to get NP and OP swabs. And the peak volumes at that point were 400 patients per day. And at least last week, they've seen a total of 8,000 patients total since opening. Patients who are sick or a bit sick can go to the care clinics, which they serve as primary and urgent care clinics. They have diagnostics such as blood work, ECG, and chest x-ray capabilities. And to date, they've seen approximately 500 patients. If these patients are sick, they can actually go to the emergency department directly. And that's really the common path point for all of these sites. Whether you're at the assessment center, the care clinics, or a member of the public, the common endpoint is coming to the emergency department if you feel sick. There's also a directive where patients can go from the emergency department back to the care clinics if it gets overwhelmed, and I'll show you that in the next slide in our surge capacity. Now, vulnerable patients have a bit of a different path that they can take. Of course, if they're sick, they can go straight to the emergency department, just like any other patient in Ottawa. Otherwise, the inner city health patients, this is actually run by Dr. Jeff Turnbull. And what he has here is a site where homeless patients can self-isolate, get alcohol and cannabis, and also serve as a safe injection site. They also have physicians on site that can provide daily care to these patients as needed. For long-term care facilities, there's a community paramedicine model. These facilities can call a phone number directly, and they get triaged by a paramedic. The paramedic can provide therapies and give advice if it's in the scope of practice. And if there's extra resources needed, or it's outside the scope of practice, there's actually a doc-in-the-box strategy in place. This is similar to what happens in Orange, where the paramedics are able to call the physician who's on call, who can then help deploy resources further, including family physicians. There's also GP home visits that can occur. And of course, again, if these patients are sick, they can all come to the emergency department directly. All of this really serves two purposes. First, it's to defer C-test 3s and 5s that can be safely treated elsewhere outside the emergency department to prevent overcrowding in the emerge. Secondly, it's to build a system that can effectively treat and care for both COVID and non-COVID patients. Imagine if all 8,500 patients seen by Brewer and the care clinics all came to the emergency department within a month. That would severely overwhelm our systems of what we have. We've also received a lot of questions about projections. We did feel that projections are outside the scope of this talk. And if you're interested, you can visit 613covid.ca, which is put together by a team from the University of Ottawa and the Ottawa Hospital with data from Ottawa Public Health. And we can post a link in the chat after the talk as well. Now, what will happen if we see a surge? Luckily for us in Ottawa, I'll knock on wood, we haven't had a surge quite yet. But Dr. Wilmer talked to us about what strategies we have in place if this is to occur. And there are many strategies in place to prevent our system from being overwhelmed. First, there's a regional patient flow strategy, where you have a regional flow manager who's aware of the bed status of hospitals around the entire Champaign-Lynn. This person can help redirect and spread admissions out across various different hospitals, so no singular hospital is overwhelmed by COVID patients. To free up hospital beds, there's plans to decant ALC patients to peripheral hospitals. And as I mentioned previously, there's a directive that exists that if the emergency department is overwhelmed, they can redirect or deflect low acuity patients back to the care clinics. Also with long-term care, there's currently the long-term care facilities are not accepting discharges of patients who have confirmed or suspected COVID. To mitigate this, there are plans in place to open a 146-bed transitional care unit to allow for convalescence of COVID suspected or positive patients after they've recovered and are awaiting placement. So what all these systems are in place are, the strategy is to prevent our system from being overwhelmed if a surge is to occur.
We just want to end by summarizing a couple of key points of our talk. We know that COVID-19 presents with a broad spectrum of illnesses, with fever, cough, and shortness of breath being amongst the most common and well-described symptoms. Unfortunately, there is no perfect test. CT is not practical, and we would not recommend routine CT for diagnosis. PCR is probably best in the first 7 days of symptoms, and unfortunately, serologic testing is probably not reliable until at least 2 weeks of illness. So, if you have a high pretest probability, we should assume these patients have COVID-19, regardless of their test result. And we know that asymptomatic patients do exist. However, we're unsure of how infectious they are compared to those who have symptoms, and what exactly their role is in the spread of this virus. We've seen, based on the great variance of mortality rates across countries, that mortality rates are modifiable. And that although age is a predictor of mortality, frailty may be more important. Just think of that 50-year-old with multiple comorbidities, advanced COPD, coronary artery disease, diabetes, and chronic kidney disease. That person probably has a higher mortality rate compared to the independent, healthy 70-year-old. For patients who require ICU level care and mechanical ventilation, the mortality rates are extremely high. And thus, it's absolutely paramount that we establish goals of care early in sick patients with COVID-19. And we've ended our talk off by showing that there's a robust strategy for the management of COVID-19 patients in the Ottawa region. So this is the end of our talk, but we wanted to leave you with a few parting thoughts. That although the rest of the world is temporarily closed, emergency departments across this country and across the world remain open 24 hours a day, 7 days a week, 365 days a year. We're here to treat anyone and any illness that shows up at our door. And to each and every one of you working through this pandemic, you're not just heroes for a single day, but heroes every day for the work that you do. I want to take time to recognize our colleagues who make our work possible and keep us safe. To the nurses, RTs, PSWs, housekeepers, and support staff in hospital, to the first responders, grocery store clerks, and food delivery personnel outside of the hospital. Thank you for all that you do.
We want to end by sharing a quote from our former program director, renowned inspirational speaker, and emergency medicine coach, Dr. Stephen Bernard Choi. COVID-19 is our call to action. It's our chance to show the world why emergency medicine is the most badass specialty out there, and to show them why we can handle anything that comes through these doors.
So as we leave you today, we have no doubt that you'll continue to wake up, kick ass, and do so on a daily basis. It's an honor and privilege to work alongside all of you. Thank you so much for joining us this morning, for your attention, and for all that you do. Please follow us on Twitter, and if you want our references, there's a link there that breaks down the references on a slide-by-slide basis, and we're happy to take questions.
Great job, guys. I really want to highlight how hard it would have been to put this grand rounds together and how much work went into this with the amount of evidence that's changing every day. So really good job. I do have a couple of questions lined up for you here. So one is, do you guys have any thoughts, and you may or may not, based on sort of what you've looked at, but any thoughts for saliva testing?
Saliva testing, interesting. We haven't looked specifically at, we haven't seen any papers looking specifically at saliva testing. One thing that was interesting to us was this slide, looking at how good sputum cultures are. So what I've been asking people over the last 2 weeks is whether or not it would be viable for us to just have patients spit in the collection bottle and send that off for PCR, as it would really reduce our exposure to the patients. And it looks like it actually outperforms NP swab in patients that can produce sputum.
Okay, great. A question related to the cardiac arrest data out of China. Did they at all divide patients by their rhythm, i.e. were survivors shockable rhythms or not?
Yeah, they had an extremely low rate of shockable rhythm. I actually don't recall if the person that survived was specifically shockable rhythm or asystole, but again, they had a really, really high proportion of asystole. So 90% of their patients presented with asystole, and somewhere in the mid 80% had a respiratory cause for their arrest. So in this hospital, which is one of the dedicated COVID hospitals in Wuhan, they were seeing cardiac arrests that were primarily of respiratory etiology.
Great. Do you know if there's any data on age stratified mortality for patients who are on mechanical ventilation?
It's a very interesting question. If you look at the over 80 column, and especially in the Canadian, so both in the Canadian as well as the US literature, you'll see that at that point, the death rate is higher than the ICU admission rate. So my best guess is that the mortality rate for patients who are intubated is probably really high for those who are 60 to 70. And I mean, it's probably really high in the patients that are over 80 as well, but I think we're not really intubating these patients. Now, there was a study published yesterday actually, looking at a cohort of 6,000 patients in New York City. And what they found was that they had about 600 patients that died and only 400 patients that were admitted to the ICU. So as our systems get overwhelmed or as we start to prepare for surge, I think there are less and less patients at the extreme of age that are getting intubated. But I would imagine that the data for mortality amongst intubated patients will follow this trend.
Perfect. And somewhat tied into that question, and I know you guys didn't want to touch on any airway controversies, but with the idea that ventilation may or may not be beneficial for a large subset of patients, your thoughts around using non-invasive positive pressure ventilation instead?
Mm-hmm. I think it's a great option. There are some papers that looked at comparing invasive to non-invasive ventilation. The data is not straightforward to interpret because those that require invasive ventilation are generally sicker than those who don't. But I think that non-invasive ventilation is a really great strategy, and we have good literature from the ARDS literature that it may portend a mortality benefit. And so I think that we should continue to use non-invasive ventilation, particularly high flow nasal cannula. But I do know that many sites are limited by the number of high flow devices that they have.
Perfect. Now, most of the discussion in the chat has actually been around this question. So if the R naught for COVID and SARS is similar, why is COVID so much more prevalent?
Yeah, I had that same question. I don't know that I have a good answer to it. That data comes from a systematic review looking at various viruses. I'm not certain. I think there's a lot of differences between the world in 2003 and the world in 2020. Certainly we see it's much more globalized world. We see much more travel. So I think it's at least in part due to that, as well as we see that across the world, population densities are increasing. So I don't know that I have a definitive answer, just speculations as to the different factors that have contributed to this being probably the worst pandemic of our generation.
And I think it's, to Jim's end, it's extremely multifactorial, and we're still trying to figure out a lot about what COVID-19 really is. A lot of the slides that we presented for the pathophysiology even is what we hypothesize, and I think it's there's a lot of factors at play that we probably aren't aware of yet. And as we kind of progress throughout this pandemic, we'll figure out more answers as to why it's so virulent compared to other viruses that we've seen to date.
I think Miguel had a comment here to add on to that. Miguel, do you want to chime in?
Yeah, thanks, Shiva. So I can comment on the R naught, and then I had a second comment about the saliva. So regarding the basic reproduction number, or R naught, it's a really useful value, but it's a very independent variable. Ideally, it's totally isolated to other factors that can influence how a disease is spread. And it's what really drives the R naught are the duration of how someone is contagious, the likelihood of it being transmitted, and then also some external factors like environmental, for instance. So the assumptions are that anybody around a patient who has the disease would be unvaccinated and vulnerable to acquire that disease. So it's a related parameter to the basic reproduction number there's a few. There's like the effective reproduction number, time-related reproduction number, or control reproduction number. And these are more useful, in my opinion, because these take into account the public health interventions that a system is implementing. So for example, when you implement social distancing, the R naught does not change. That's an inherent value to the disease. But when you implement social distance, the control reproduction number goes down. When that value is below 1, that's when you can start alleviating your public health interventions, because the disease is spreading to fewer than one person with those given interventions. I hope that's clear, and I can provide some papers if people want that kind of explain those concepts a little bit more. And then the second thing and what I wanted to add to that is that's part of the reason why the studies that look at the R naught for COVID-19, they go as low as 1.5 to as high as 5.5, is because it's hard to separate the true R naught from all these other interventions that different jurisdictions have implemented. And then the second question about the saliva. So there's a few studies that have looked at the performance of saliva. The only study that has looked at how it performs at a population is not published yet. There's a preprint study available in medRxiv that I can put in the chat. It's in an inpatient population with a little bit higher severity of disease. So I'll post it in the chat, but it should really be evaluated and appraised with a lot of caution because it has not been peer reviewed yet.
Awesome.
Thanks, Miguel. You brought up a really good point that I forgot to mention. A lot of the studies that we used when we put together this study are from inpatient data. So all the published literature that we cited is predominantly from inpatient data. The exceptions being public health literature and that one Burr et al. And the Diamond Princess cohort, which were done in outpatients.
Awesome. The next couple of questions you guys may or may not have answers to, and so that's okay. They kind of pertain to local data. Do you know if the rate of patients who are vented in Ottawa are similar to other sites so far?
Unfortunately, the only data we had available was public health data, and public health data is not, I do not believe releases that data, but Brandy might know better than we do.
Maybe not. Okay, next question. Again.
Sorry for Brandy. It was the question had to do with rates of mechanical ventilation amongst COVID patients in Ottawa, and I didn't recall seeing that data, but we weren't sure if you knew if that data was being published. Rory, and then we had also questions about mortality of vented patients here. Again, unfortunately, we don't have that data available to us. I mean, we don't have a ton of COVID mortalities in Ottawa, and so our ends would be really small and spread out across the various hospitals in the region. So I don't think that we have enough robust local data with regards to mortality rates, ventilation, etc. But maybe if Mike Hickey's in the chat, he can speak to that.
I don't know if Hickey's here, but just to continue the questions, again, may or may not have an answer to this, but anything you guys read related to thrombotic complications?
We didn't look specifically at it. Now, we know that there's been a lot of buzz in the foam world about COVID-19 being a prothrombotic state. I mean, prothrombotic states generally occur with acute illness, hence why most patients admitted to hospital get DVT prophylaxis. But we didn't look specifically into whether or not patients require anything more than that. But we do know the D-dimer is a predictor of mortality, specifically above levels of 1,000, even more so if you have extremely high D-dimers, such as levels above 2,500.
Awesome. When does occupational health consider a COVID patient recovered? It seems like the figures indicate they're only about 50% in Canada. Is there a delay and why?
That is a good question. With regards to inpatients, now this has changed a lot, and perhaps people with better knowledge than we do can speak more accurately to it in the chat. Our understanding is that they need 2 negative swabs as from an inpatient perspective. I don't actually think we're doing tests of cure in the outpatient population.
From what I have been told, if you were positive at some point, you'll need 2 negative swabs before you're considered cleared. I don't know if that's changed in the past week or so, but that's what it was from when I looked into it last week.
Excellent. And then the last question I have for you is if you guys came across anything related to ECMO and whether there is some utility in a certain select population of patients.
In the Chinese literature, there's a subset of critically ill patients that went on to get ECMO. Those numbers are in the single digits or low double digits. So I don't necessarily know that we can say there is a subset of patients who undergo ECMO, but I'm not sure we can say what the role is. I imagine that it should be similar to other to ARDS management and other single system issues with regards to who would be a candidate for ECMO.
Awesome. That's all the questions I have right now, unless anyone wants to chime in with anything before these guys run away, or if you have any final thoughts you want to add. Okay, I guess we'll call it there. Really good job, guys.
Thanks, everyone.
Thanks, everyone.